I'm going to move on to Dr. Lawrence, who's going to talk about tumor emergencies. This is kind of an awesome topic that we all fear. What if we get called about a tumor in the middle of the night? I don't want to mess something up. How do we handle tumor emergencies? So thank you. Great.
Yeah, thank you to Matt and Katie for putting this together, and happy to be with you, especially amongst such esteemed panelists. I'm going to go over maybe some of the same ground that Larry touched on, but um, appreciate it. No disclosures for this talk. So here's a scenario. I mean, patient presents with either acute pain, localized, radicular, mechanical back pain, may have weight loss or other B signs, with or without a neurological deficit, perhaps bowel and bladder impairment, and maybe known or unknown oncologic history with an imaging study like this. And it can create a lot of concerns and certainly raise a lot of questions for us, at the outset. What's our differential diagnosis? What other imaging do we need to get? What might the prognosis be? And what does it mean for the patient and their future? Do they need immediate surgery? Is a biopsy the next step? And do we have to talk to our colleagues from interventional radiology or medical oncology? And really, what's the next step? And the questions can be voluminous. But I think, as Larry alluded to, the sort of thoughtful approach utilizing the NOMS framework, even in the patient with an emergent lesion, can be really illustrative. So we don't rush into surgery, so we have good decision making. Is really critical. So we'll talk about that. I'm going to go over some of the same information a little bit. I'm an orthopedic spine surgeon, so the intermedullary and extramedullary intradural tumors are a little bit out of my sphere, at least when I can help it. But the majority of these are going to be metastatic lesions that are extradural. So I'm going to focus a little bit more precisely on that and leave the rest to my colleagues in neurosurgery. So the NOMS framework, I think, is a very valuable framework to think about how we evaluate patients with spinal metastases, even in the emergent setting. And this is Dr. Lawford, Dr. Bilski's work, as mentioned, from 2013, looking at these four key criteria for decision making between radiation therapy alone or separation surgery, or whether or not the patient needs stabilization and or radiotherapy. And then I think, very importantly, taking into account the systemic nature of the disease, the patient, then really focusing on outcomes and bringing that to the fore, even in the acute decision-making timing, I think is very important. So just reviewing this quickly, the neurologic, I know we may have a lot of generalist orthopedists, so the neurologic refers to the degree of epidural spinal cord compression, either low grade or high grade. Oncologic is just a basic understanding of the relative radiosensitivity or radioresistance to radiotherapy. Obviously, the hematopoietic lesions, myeloma, lymphoma, being exquisitely sensitive to radiotherapy versus the more resistant lesions that you see on the right. And as mentioned, with the SINS criteria favoring increased points for junctional lesions, having the presence of pain, characteristic lytic behavior, malalignment are all alarming and gain more points. And this is an effort to sort of put all these criteria together to guide us on the next steps, as you all know very well. And it reflects also, with the SINS criteria, this evolution from the classic White and Pajavi definition of instability with the degenerative or traumatic spine to the sense of neoplastic stability, as mentioned by Charles Fisher in 2010, the ability of the spine not be able to tolerate loading when it's exposed to physiologic loads. And the SINS criteria are very useful, but they're also very, very high inter-observer reliability. So there's a lot of benefit to that, with communication between centers, for areas for research and for communication among surgeons as well. And just as a backdrop, looking at the landmark Patchell study from 2005, looking at primary outcomes of ambulation with patients, the history, of course, is that surgery in the acute setting was perhaps not favored. This really changed the thinking of spine surgeons and radiation oncologists, as well as the general medical community, looking at surgery plus radiotherapy as being a real potential advantage in increasing patients' early mobilization and having improvements in secondary outcome measures as well, and improving mean survival. So surgical techniques that can be focused on even in the acute setting are really understanding what the indications are for surgery, what the goal is, en bloc spondylectomy versus decompression, separation surgery, whether or not the patient truly needs a stabilization, or whether or not that stabilization can be achieved with something as simple as a vertebroplasty or kyphoplasty, as well as does the patient need multi-level instrumentation, or do they truly need a fusion? I think this is a great area for discussion, amongst us in the general spine community. If the prognosis is a very favorable one for the long term, I favor doing a formal fusion as opposed to simply instrumentation and stabilization, because the patient's going to live many years. I'd rather not deal with a non-union or instrumentation failure, but it's really a judgment call, particularly in the acute setting. And then choice or selection of different treatment approaches can vary really widely. We're all migrating toward trying to do surgery less invasively. That certainly bears true in the treatment of the patient with spinal metastases. I think the transthoracic approach for me is quite morbid, and the thoracoscopic approach has a very steep learning curve. But trying to adopt MIS principles and applying them to the tumor setting, I think, can be very advantageous for several reasons. But one of them being healing, and earlier healing can allow the patient to get into radiation therapy much more quickly with a lower complication rate. I personally also find that usage of navigation to be very, very useful, not only to help with screw placement if it's necessary, but also to just guide where I am as far as the decompression, trying to ascertain the completion of the decompression, trying to refine end plate preparation if you have to do anterior column support. And then we don't have carbon fiber screws in my center, but I've seen the differences in imaging. There's a real avenue for increased utilization of that. My radiation therapy colleagues are very big fans of using carbon fiber or alternative instrumentation technology, because their visualization is so much better, and it really helps them plan radiotherapy with higher precision. So this is all moving us toward when surgery is indicated in the acute setting for the patient with instability and high-grade epidural compression and a positive milieu for the patient. They're gonna survive. They're healthy enough. Trying to move toward using surgery to reduce pain, but to reduce complication rates by pursuing it less invasively, and then trying to get the patient to earlier, more successful entry into radiotherapy. I try to reinforce with my residents and fellows that surgery may not be the implementation that saves their life or necessarily prolongs their life, but it's the best way to get them to the long-term treatment that may do so. And the sooner we do that and the more safely, I think really, obviously, the better. And then looking at outcomes, as was alluded to earlier with the SORG, normogram, and et cetera, I find this very, very useful. And I'll just take you through it a little bit, but we've seen this big evolution toward bigger data, artificial intelligence application. This really helps us know a bit better prognosis, more accurate prognosis, even in the patient presenting with an acute lesion who may need acute surgery. It just allows us to better advise the patients on long-term survivability. And taking all these criteria into account, as you see here on the right, I as well have gone to inputting this into the website that you see below, and find it very, very illustrative to counsel patients on what the future may hold, what their outcomes may look like, and whether or not surgery is really in their benefit. And this is in contradistinction to the accepted things we used to talk about, where if the patient is likely to have 3 months of survival, then surgery really may benefit them. But this gives us a lot more detail and a lot more kind of a refined conversation that just helps the patient, also helps the medical oncologist, because in my center, at least, if there's an acute setting, the medical oncologist just may not be available, or may not be available to have that sort of very important conversation with the patient over what the future may hold, with or without surgery. So just summarizing, I think utilization of the NOMS framework, knowledge of the SIN score, understanding the SORG, normogram, and algorithms are very helpful for us managing spinal metastatic disease, and multidisciplinary care is really critical. In our center, we've been able to work with radiation oncology and to have basically a floating tumor board where any patient who's recognized in our health network, we're immediately communicating with RADONC and IR medical oncology to try to get that patient the right treatment as soon as possible. And many times that first treatment is the surgeon. going through this. So just a quick case. This was a 67-year-old female who presented on a late Friday evening, did have a positive history of a renal cell after a radical nephrectomy in 2014, presented with insidious onset mid-back pain and some gait instability. Didn't have fevers or chills or obvious major weight loss. Normal bowel bladder function. They were hyperflexic with sustained clonus. Labs were not overly impressive. Just referring back to what we saw before, perhaps a winking owl sign on the AP radiograph, presence of some scoliosis, which made things a little bit more challenging here. But CT scan demonstrating a lytic lesion in T11, clear extension into the pedicle, solitary lesion, MRI helping understand there's high-grade epidural compression, significant entry into the posterior elements. Not a tremendous amount of deformity, however. It's just a stir-weighted image. So direct application of the NOAMS and SINS criteria, you have high-grade epidural spinal cord compression. Based on the history, it's likely to be a relatively radio-resistant lesion, given that it's likely to be a renal cell. Looking at the SINS criteria, there's junctional involvement, presence of pain, obvious radiolytic response from the tumor, small bit of scoliosis and posterior element involvement that was very significant, scoring to 13, favoring surgical intervention, systemic evaluation, normal albumin, hematocrit of 29. If we look to the SORG normogram or algorithm, plugging in the data as I do now and have my residents and fellows do, gives you an estimated survival of this type of lesion with the patient's particular context. 6-week survival predicted at 86%, 90-day predicted at 64, and a year at 42. But to my mind, that's reasonably promising to favor surgery as a positive intervention. I would also say anecdotally, I think renal cell with modern immunotherapies has really changed prognosis to be sometimes much more favorable to that, although I certainly have a lot to learn from that standpoint. So treatment options at this point for this patient favoring surgery, but obviously there are other factors involved. Renal cell tends to be a very vascular tumor. So this was an example where I got on the telephone to try to find an interventional radiologist or neurosurgeon to help me with embolization, as I thought it was a very, very high priority. In consideration of treatment approach, I favored posterior approach for this, but I don't think it would be inherently wrong to approach it anteriorly and posteriorly. I'd love to see what the panel has to say. Decompression, circumferential decompression being a goal to favor early radiation therapy, but whether or not you have to really reconstruct the anterior column. I think in this setting, if I was in surgery and had significant problems with ongoing blood loss or hemodynamic instability, I might shy away from that. But if the blood loss was tolerable, the patient was stable, I think anterior column reconstruction can offer some real benefits here. And then, does it need to be truly open versus MIS? I think in my hands at this time, I was a little more comfortable managing it open, but I think many of my colleagues would favor an MIS approach through a tube with great results. And then whether or not just an instrumented stabilization versus formal fusion, I think in my mind with a renal cell, perhaps positive prognosis, I favor an open bony osseous fusion, but love to hear everybody else's thoughts on that. And whether or not PMMA was indicated based on the bone density. So we did a preoperative embolization in this particular circumstance, and I think got very good access to the tumor's vasculature. Then took the patient to surgery, performed instrumentation first under navigation, did a large decompression circumferentially, a large anterior decompression or partial vertebrectomy. The goal simply being not complete tumor resection, of course, but just circumferential decompression. And in this case, I did do anterior column support for them as I was worried about the effects of long-term from radiotherapy and stability. And then staging with radiation oncology in preparation for radiation therapy, the goal being to try to get them into stereotactic radiation within really 2 to 3 weeks if the wound was favorable of that. And in this case, at least, I think we had good separation achieved for this particular case.
I love that case, James, because it's just the scariest. You've got high grade compression, you've got acute neurologic changes. It's Friday night. This is such a multidisciplinary case, and you're the only one working at night. So I guess to you and to the panel, when you know the right answer is embolization or pre-op or maybe even radiation alone and no surgery for very hypersensitive histologies, how do you what do you do if that's just not a resource that your hospital has? And how do you manage that?
I mean, I can speak to that. I think it depends on the situation. I think if the patient is rapidly, progressively, neurologically deteriorating, then I think sometimes we have no choice and we really do the best with what we have. But in a case like that, I think it may have created some real compromises with say, the anterior column support for that matter. I also think the utilization of common hemostatic agents is really invaluable. TXA among them, usage of Everest, which is a military hemostatic product that we now have accessible to us. It's been very useful. But I've been lucky in our center at having interventional radiology available. I think if I were in a smaller setting or community setting, I think this would be a phone call and a transfer to a setting that does have it. Because I think I've seen or heard of people having truly life-threatening bleeding from an operation like this, and that I think I would not like to be in that situation.
Any comments from the panel? How would you have handled this in the late on a Friday night at your center?
What was the patient's neurology?
They were myelopathic, but not severely progressively deteriorating.
Yeah, so I think I would have managed it the same way. I would have, gotten a Saturday embolization or an urgent embolization, taking care of it, especially in a renal cell. You don't want to be at 2 a.m. dealing with, you know, uh, large transfusion protocols with insufficient anesthesiologists and potential, you know, uh, cardiac and respiratory implications of that. But I agree with Dr. Lawrence on, what he said. Unless there's acute neurological decline, if you don't have the ancillary resources to take care of something like a highly vascular tumor, I think it does make sense to transfer. But in the setting of kind of neurological extremis, I think even renal cell, which has this big fear, or certain metastatic sarcomas have these big fears of bleeding. It is certainly manageable. Using burrs, coarse diamond burrs to try to get hemostasis in the bone, using having the flow seals and hemostatics prepared, and using TXA. I know certain when we started using TXA in oncological settings here, we were getting some reluctance from our anesthesiologists, and over time, showing some of the published literature on it. We're not doing it as high doses as we do in our deformity cases, but we certainly are using fairly high doses. Usually we're doing a 10 mg per kg bolus and then followed by 2 mg per kg per hour of TXA, which I think is also tremendously helpful.
I will add that, thanks, great comments. I will add that much like any of the complication management sort of routines that you set up, how am I going to deal with a neuromonitoring change in surgery, any of the routine things that spine surgeons do, I think this is no different. I think if you're going to see tumors and you're going to tackle them and you've decided that's something you're going to do, before you see this case, you make sure you're pretty good friends with your IR team and your radiation oncology team, and you discuss, maybe not a formal call schedule, but hey, here's how we're going to respond if indeed we find ourselves in this situation. So it's always better to think about things ahead of time rather than in the heat of the moment. Is just another comment I would have.